Anyways, we're wrapping up. Are there any questions? I do not know who is left here, but thank you. We still have a lot of people here. I'm hoping some questions may pop out by any questions, Salis or Al?
I have a question for Dr. Taylor. When you talk about cytokines and lymphocytic activity, so have you looked at the role of using manual therapies that absorb those type of cellular activities? So I'll expose on pelvic PC. So that's my role in endometriosis. I was just curious what you guys have done in your lab.
Yeah, we've actually not collaborated much. I went for the first time to the IPPS meeting.
Right.
In fact, you look kind of familiar with
Right.
it. Yeah, so, so that's, yeah, I think these multidisciplinary approaches, though, and that's something we've really not incorporated as much in my own, in my own practice. The sort of manipulations to manage endogenous immune cell function is not so well understood. There are a lot of therapies that are promoted to sort of alter immune cell populations that I don't think we actually understand well enough now to really be able to, in my own experience from what I've read and the patients that I've seen. Now, I'm not at all, I don't doubt that in the future when we actually have approaches, maybe nutritional, certainly, exercise, other things that, where PT, perhaps, massage and things like that can really be shown to be beneficial in this direction. I think that we do have the ability to kind of manipulate the kinds of immune cells that are circulating. Whether we can really change how those are attracted to individual endometriotic lesions is a kind of another question. And I guess one of the things that Serdar actually pointed out in his presentation as kind of a hypothesis or a speculation is that endometriosis cells with these kind of stem cell characteristics have the ability probably to take on some of the phenotype of immune cells themselves. So what we attribute to immune cell activation of endometriosis cells might actually become incorporated a little bit like the ability of those cells to make their own source of estradiol. They might be able to make their own cytokines and things and possibly evade normal kind of immunological responses. So I think that there's going to be a lot of different things that develop in the future, and I think we should have an open mind about all of those.
Yes, Susie.
I have a question for Dr. Taylor. Still, okay. So you mentioned that in endometriosis, the immune cells and the cytokines are involved. My question is for endometriosis surgery, after you incise the lesion, how about the healing process? Will the immune cells and the cytokines also involved, and what's the differences?
Well, so that's something that I don't know that we've studied very well either. But yes, the healing process is definitely an inflammatory response. There's no question about it that if your immune cell population is depleted, you don't heal wounds, skin incisions, all of the various things that occur don't happen in a normal fashion. Now, as has been pointed out here, it's possible that some of this inflammatory response is over-exuberant, that there's too much of an immune response, there's too much scar tissue formation, there's too much of an inflammatory response. So I think in the future it'll be interesting to see if we can actually develop ways of kind of modulating wound healing in the post-operative setting. The difficulty there is going to be we obviously don't want to impair normal wound healing, but we also don't want to introduce excessive adhesion formation, which we know is a real problem in endometriosis, particularly with repetitive surgeries. And adhesion prevention approaches with mechanical barriers in my own experience, I've not been so satisfied with how those have worked. But I think that it's an interesting idea to think, can we do immune modulation right around the time of surgery, and would that have a kind of an effect on long-term, decrease the risk of recurrence? I think would be an interesting question.
Thank you very much. I have another question for Dr. Okta.
Dr. Okta is here? Yeah.
Yeah. So,
I didn't know I was going to get a question, so.
as far as the DNA repair is concerned, so do you think is there any role about the low egg quality in endometriosis patients, about the DNA repair damage?
So your question has two parts. One is that there's low egg quality in endometriosis patients, and the second part is
is it DNA repair inhibition also got involved in the low egg quality of endometriosis patients?
I'll take it in two parts. First of all, we're not so sure that egg quality is altered in endometriosis. We know that if you do too much surgery on their ovaries, you can't alter ovarian reserve, but I think the egg quality part is a bit more debated. However, I wouldn't see any difference if there's diminished egg quality in endometriosis. I would expect DNA repair, decline in DNA repair to play the same role. Obviously, we don't know the overall impact of declining DNA repair. There could be other things. I mean, I didn't have time to discuss. One of the interesting things about DNA repair pathways, they're also involved in telomere function. Before telomeres involved, that pathway is so preserved, so primordial, they were actually doing the job the telomeres were doing. In BRCA mutant individuals, actually telomere function is also altered. So there are lots of mechanisms there. Whether endometriosis adds to that, that's an interesting question. I don't know if anybody has done research in terms of looking at DNA repair function in endometriotic implants or these patients. Could that be related to that? Aromatase function is related to BRCA as well. It's a suppressor of aromatase enzyme, which is important for endometriosis, breast cancer. Probably one of the mechanisms why these women also develop breast cancer is in a BRCA mutant situation, aromatase suppression is less. So there are a lot of complex interactions possible.
Thank you very much.
Okay.
Well, I think we're just, on the schedule, we have a panel here, but I guess these questions and answers are going to replace that panel since we are very friendly all together. I appreciate everybody staying here. My comment, is there a question? Oh.
Just one question to Dr. Berger. Hi. Just interested in the fact that you found the brain function to improve with estrogen replacement in postmenopausal women, whereas there was a study which was long-standing. They said there's a deterioration of mental function with the use of, especially with progesterone and estrogen use in postmenopausal women in a prospective study of nurses' study. And therefore, it seems to be very contradictory. You obviously have done a scientific research. Is it possible that that was just observational rather than a real scientific study, the previous study? I know many flaws were there in that study, and now Menopause Society has come up with reversal of certain dictums which were passed on so many years back to all of us, and we're not using hormone replacement at all.
Right. So it's a pretty controversial topic, and I think you're referring to the Women's Health Initiative.
Right. Sorry. Yes.
And then they had the WHI memory study, so WIMS, and it wasn't actually designed into the study. So I was a co-investigator of the WHI, and belatedly they decided that they should collect some data. So they did some after-fact survey data. So these are just inventories, psychometric inventories of performance. And then they looked at diagnoses. And so the study itself has lots of little issues in terms of randomization. But the biggest problem was that they didn't have very many people with dementia of any type. So the entire conclusions are based on about 50 patients out of a large data set that developed dementia. And it's a common rule in epidemiology and population science that the larger the number that you study, the more likely it is that you have an accurate answer. So subsequently, people have gone on to design better trials. I think I showed you what I think is the best one, which is the Cache County study. And they, every 10 years, update their study. So they've got a more detailed update of the study. I showed you the initial one from 2003, 2004, which I think is just easier to show because of the clarity of the graph. But the same conclusions pertain. And then other studies have been done, so I showed you just a few of those. So if you look at it just from population science, you know, it's starting to shift in the other direction, the pendulum swinging. When you add in the other data from molecular studies, animal studies, mechanism of action studies, it starts to be more persuasive. So it's true that this one study, and I actually was in the newspaper quoted about it, and the time it broke out, I actually got to see the data and write a little editorial. This one study really had a large impact because it came early in the, what I would say, the fear phase of the WHI news. And then it didn't go away yet because people are still fearful. And fear drives a large part of how we think. So it's really hard, even if I tell you all these facts about other things, to overcome that fear that got started. So I think that's where we are. But I also will say that we haven't done a complete due diligence on this topic. And there's lots left to be done in terms of dose and type and how long and when. And so more we have to ask detailed questions in order to have better advice for you. So the big picture is stay tuned, and hormones play a role. The little picture is we need more details to really be fully able to advise people depending on their circumstances.
Thank you so much.
I don't know if that helps you, but
it's very interesting. Thank you.
Okay.
I just want to make a couple comments on the record as we closing just about very soon. As you know, we have given, with our limited sources, close to $500,000 for research in the last 2 years or so. That is significant. An organization like us can do that. We are not trying to invent something spectacular, but encourage the community that research is one of the most crucial part for endometriosis, facts to be found on endometriosis, because this disease still, as much we try, even though there's some awareness going on, we're still very, very behind. So I am looking for private money to basically flow into this. We will do everything to do that. So I need your support as far as if you have ideas how to structure finding the right research. I like to hear your comments, and I think this year again we will give again close to $250,000 for the right researcher. The second thing is, on the record, I like to express my gripe against IVF practices in the United States. It's not only, you know, we all know, but I think the awareness and education of women when their chances of fertility seeking goes beyond 35, very few realizes that chances get so slim, and you feel so bad that they all get disappointed mostly on this path. Unfortunately, there's not a single IVF clinic I know that asks any specific endometriosis questions to the patients. For them, endometriosis is just endometrioma. Unbelievable. And I do not know what to do about this. And unless we really do one meeting about this scope of our concern in the future. I just want to express this on the record, and we know that because I see a lot of these patients, and many of them get pregnant after excision surgery in the following 3-4 months by themselves. There are so many stories like that, and you all know that. This meeting was about sex steroids and endometriosis, ovary, and breast. but it's about also inflammation. I think the value of understanding inflammation in every disease, particularly endometriosis, is so crucial. The most physical aspects of endometriosis, or quantitatively, the pathology quantitatively, physically, is fibrosis. It's the fibrosis that is on a superficial layer distorting the peritoneum. It's the fibrosis that distorts the organ and causes organ dysfunction. So in that sense, I hope your perceptions will change with this meeting. And it's important to understand the value of teamwork from my perspective as a surgeon. And these surgeries do take multiple surgeons many hours to do in the right way. Even I personally think early endometriosis surgery much difficult than the radical big surgery, because in obviously challenging big surgery, bowel resection, endometriosis, you know what you're going to do. In the other one, you really have to seek for lesions, and there are lesions. There are lesions. These women are not waking it up. And I know it. Hopefully, we will one day publish our patient satisfaction reports. They are doing well, and they cannot. They're doing well beyond 3 months. So, good excision means a lot for these patients. This peritoneum has more physical value than just a transparent organ, or it's superficial, or start the medicine. It's not. Every lesion is connected microvascularly to a nerve underneath in that inflammation process. I learned a lot. This was a very challenging conference for me. I honestly was I was particularly very nervous. As I told you, I had my personal reasons to do this, but I'm so happy, even though we touched every corner of in our medical field that estrogen touches as target organs, including brain and the fertility elements. I learned so much. I couldn't have learned this any other meeting that I would go for endometriosis, because I know it all. Everybody is repeating the same thing. So it's nice to like Kutluk's one of the translational. It's nice to translate what we do to others and learn from others, because I don't know who said that. We have grown so far away with this speed of technology and knowledge and the research. I can't follow what he's saying. I don't think anybody can, even as a physician, and beyond certain level. But I am interested to go back and take a look again, understand that. I am challenged. I think that makes me very happy. I am interested to learn any time in my life. Anybody else? I really appreciate. I'm going to close at 6 o'clock. Thank you very much. It was very, very nice. I congratulate you. I mean it. You made history today. So it's going to be marked. And we had above 5,000 followers on Facebook today that watched the whole conference, except the breast reconstruction section. Facebook shut the site down. And then they reopened again. They were following, apparently. So I just, for the record, yes. Thank you very much. I really want to put that thank you slide, so I don't want to forget anything. I particularly want to thank Leslie and Jean, Leslie Crushfeld, who is our interim executive director, Jean, who helped us for everything we needed, Sarpar, without him we couldn't have done it, Suanne Harrison, Carly, Denise, my wife, my family. Thank you very much for giving us a hand. Thank you.